our graduation ceremony last night in the same room, and I apologize for the detritus in the back of the room. If there were food left over, we'd probably bring it somewhere, but in any event, sorry for that. We're really honored to have Charlotte Cunningham-Rundles with us here today, who is the David S. Goetzman Professor of Immunology, as well as Professor of Pediatrics and Professor of Medicine, all at the Icahn School of Medicine at Mount Sinai. She is co-director of the Allergy Immunology Fellowship at Mount Sinai and acting chief of clinical immunology. She received her Bachelor of Science in Chemistry and Zoology from Duke University, her medical degree from Physicians and Surgeons at Columbia University, and then her PhD in immunology at New York University. And over the last 4 decades has been a brilliant pioneer and intrepid explorer in the world of primary immunodeficiency and the many, many rare diseases that have that as an umbrella term for thinking about them and how they manifest in humans. Dr. Cunningham-Rundles, over the course of hundreds of manuscripts, chapters, books, presentations all over the world, has helped us in so many ways to better understand these immunodeficiencies and these very significant impact that they have on the lives of patients and their families. She is the founder and the PI of the U.S. Immunodeficiency Network, which I imagine many of you are familiar with, and continues to do wonderful work. And as a person also interested in rare diseases, has really given us a way to establish and understand a path for patients with rare diseases by way of the combined variable immunodeficiency network that she supports and the work that she's done over the last few decades following those patients in their natural history. Her most recent article described more than 450 patients with that rare disorder and how they look over time phenotypically and how their lives go. I don't want to close without saying that in the course of her work, Dr. Cunningham-Rundles has obviously supported thousands of patients in navigating their lives and understanding their lives, and really has looked at the entire continuum disease, all the way from genetics to mechanisms to phenotypic presentations and therapies. And we're so honored to have you with us here today. Thank you.
Thank you very much for that extremely warm introduction. I appreciate that very much. I was trying to remember, I did either medicine or pediatrics here. I think it was medicine because I was a student at Columbia. So it's kind of nice to round the bend and come back to tell you what happened in the meantime after a long period of time where I got into the world of primary immune deficiency, which was kind of a surprise. So it came to me actually through my PhD. When I finished my PhD on immunology, it was on IgA, by the way. The question is, what do you do for a living? You know, like IgA is wonderful, but you know, somehow you have to go out there and be a doc. So what ended up happening was that I went to Sloan Kettering and was mentored by Bob Good, who did one of the first bone marrow transplants in the world for patients with immune deficiency, and I learned a lot from him. And in the course of that, sort of got addicted to the idea of primary immune deficiency. But you have to remember, I'm an internist as well. So those two things seem to be primary immune deficiency, internist, like how do those two get together? And the honest truth is that there's many, many more people who have an immune deficiency who are adults and not children. So although probably somewhere in your brain you're thinking, I probably don't have to know this, the answer is you do have to know it. And the reason why, otherwise, you'll be missing patients that actually have something rather catastrophically wrong, and you'll be the guy to pick it up. So first of all, they're genetic, they're not acquired. There's around 300 of them now that are known. I'm sure there'll be another 15 or 16 named this year. Every time our committee gets together, the World Health Organization committee, to name these, we add a bunch more because it turns out there's another gene. Ah, yes, that gene, here's what it does. So first of all the immune system components are involved. It's children, adults, children, infants, adults of all ages, and then collectively it's about 1 in 10,000 people. So 1 in 10,000 doesn't sound extremely common, but remember, we're in a hospital. So that's on the street. We're not on the street, we're in the hospital. So in the hospital, it's much more prevalent than that. And then put it in context, everyone here has seen lupus, cystic fibrosis, hypothyroidism, diabetes, leukemia, and arthritis. Everyone has seen those things. So you've probably seen immune deficiency too. So there's a committee that gets together to kind of say, oh gosh, these things are just catastrophically, growing up like mushrooms in a way, how many more diseases there could be. So somehow you have to sort of like categorize them, put them into pockets. So basically you and I can deal. And when you're a house staff member or you're an internist, somehow you need to sort of like think which category could be broken here. And so this is a way of kind of categorizing them. It's things you probably would have recognized have been true now for about the last 50 years. This is the way they've been sort of divided. It's just that they seem to be collecting a few members along the way. So immune deficiency for cellular, that's going to be things like mostly severe combined immune deficiency, for transplant time and things like that. And then immune deficiencies with associated or syndromic features. I don't want to tell you about all of these. It would really not be very useful to go into all of these today, but that would be something along the lines of Wiskott-Aldrich syndrome, where there's going to be platelet disturbances as well as immunological problems. There's antibody problems, immune dysregulation, phagocytic disorders, and going down the list and ending with complement, and then this newer category, inborn errors of immunity due to innate immune cell dysfunction. At the moment, that's just kind of a useful framework. There's a publication that came out earlier this year that kind of puts them into a category if you ever kind of wanted to go back and just say, well, how did you think those things? So what do you think would go wrong? This is fairly clear, right? Somebody has something wrong with their immune system. First thing you think about is infection, chronic, unusual infections, catastrophic infections, or repeated infections, unusual organisms, commonly respiratory disease. I would say about 85% of them will have respiratory disease. That makes sense. Gastrointestinal disease and other mucosal surface. That makes sense as well. So terrible GI disease. Abscesses, interstitial lung disease, bronchiectasis for no reason. Somebody who doesn't smoke, who comes in the door with bad bronchiectasis, you'd think, well, we better check out the immune system there. And then we get into odd territory here, autoimmunity, an inflammatory disease. So the question is why, if the immune system's not working, why autoimmunity? Well, it kind of stands to reason that you're missing something which is suppressing autoimmunity. And so that would be the way those would develop. And then, of course, there's a little bit of an incidence for all of our immune deficiencies for cancer and lymphoma. So I've been working in the world of immune deficiency for a very long period of time now, basically 4 decades, as you said. And so the question is, well, what does come in the door? What do you see? What do you pay the most attention to? And this is kind of the way that it works out, which is that, yes, we see some rare things. If you look over the small slivers of the pie over there, hyper-IgE, Wiskott-Aldrich, hyper-IgM, Candida syndromes, some thymic defects and so forth. But the predominant things that you see on a clinical basis, no matter where you are, the commonest referral that I get is going to be things that are wrong with antibody, one way or the other. The antibody system is not working. You're hypogammaglobulinemic on the one hand, or you're IgA deficient perhaps with a few extra frills attached, or you're IgG deficient. Your IgG is low and there's a question of how functional that material is. So you get around the pie, and it turns out that a great number of these things have to do with the way that the immunoglobulins work. So from an internal medicine point of view, the gold, do not draw the complement CH50, C3, and C4 as I did as a house staff member, because that is going to be less useful than practically anything you might else have done. Most important thing you will do is you will actually test quantitative immunoglobulins. Please forget the SPEP. SPEP is not a number. It just tells you, the ARC is a little low. That's not useful. You need to know a number. So many of them are due to lack of gamma globulin one way or the other, and the treatment for these patients might or might not be an immunoglobulin, but that's kind of a good place just to kind of start, a good place to remember. So these are the cells that are responsible. These are B cells, which grow up and become card-carrying plasma cells. That's like the tenured faculty in your bone marrow. That's why you remember these antibodies that you saw a long time ago, like tetanus and everything else. That's where those plasma cells are dwelling. They will make gamma globulin for a very long period of time. And I really love B cells. My research laboratory is all about B cells, which is a very fundable area to be in, by the way, because everyone else is paying attention to the slightly more sexy cells, innate cells and dendritic cells and mast cells maybe. But the bottom line is that B cells are basically making 20% of your serum protein. And so nature cares a great deal about them and really wants to get that particular thing right. So I'm going to tell you about a series of cases because it's easier to tell you about some cases than it is to sort of go through various parameters. Okay, so this is a 40-year-old lawyer. Now I have known him for 25 years. He's getting ready to retire to the mountains of North Carolina. I've known him for 40 years. He came in the door when he was 40. He's a very tall, slim lawyer, lives in New Jersey. He's previously healthy. He had a second episode of streptococcal pneumonia with empyema in 2 years. And he required prolonged chest tube drainage and decortication. So here he is, he's 40. He's gone to law school. He's gone through all his training period. And this is his x-ray, empyema bacterial pneumonia. Pretty dramatic picture. Would I have normally automatically have thought of immunoglobulin? No, but his internist did. He doesn't have any. So you kind of, I mean, this is why internists have a hard time. This is why I have a hard time. This is why you have a hard time. He's 40. He's A-gamma globulonemic, A, right? Why would he be A-gamma globulonemic at the age of 40? I can't answer that question for you. I don't know the answer. I don't know whether he trickled down the day before or the year before or 10 years before and he was just lucky. All I know now is that, of course, now he's been on immunoglobulin for another 25 years and he's fine. Just so it doesn't change the quandary that we have. So I get a referral like this probably about 6 times or 7 times a year of an adult patient, not exactly a youngster, who has no gamma globulin. And so clearly this person would have had a lot more difficulty should this not have been discovered at that time. So this is another characteristic feature. So if we go back to this one again, what is the take-home message here? Personally, if I had my way, everyone who had an empyema with strep pneumoniae, I would do a quantitative immunoglobulins. You might say, oh gosh, that means we'd be doing it all the time. And I'm thinking, how much do you think this cost this man? $60,000, $70,000 hospitalization. How much is a quantitative immunoglobulin? 90 bucks, 100 bucks, something like that. So to me, I would have done that for, I hope that's okay. I would have done that for basically any empyema, and especially with that organism, because that organism just loves people who are hypogammaglobulonemic. This is a lady who lives in Long Island. I guess she's a Staten Island lady. She had bronchiectasis the day I saw her. She's 28 years old. She's a smoker. She has no past medical history. In particular, she had a little bit of a cough. She thought it was a smoker's cough. And she comes into the office. I'm not exactly sure even why she made her way to anyone's office at this point, because she wasn't a person who seeks medical attention. And these are her levels of gamma globulin. She is A-gamma globulonemic as well. So not much of a medical history, except bronchiectasis here, pretty bad. And so I think for a while people said, hey, stop smoking, it's bad for you. But smoking doesn't give you A-gamma globulonemic either. And so this is the deal. If you look over on the side, in case you guys are not particularly recalling what normal immunoglobulin levels are, I just put them over here on the side. Your IgG should be somewhere close to 1,000, okay? And that would be your A and you'd be your M. And IgD you don't care about right now, and IgE is an allergy antibody, and of course her immunoglobulins are flat out nothing. She ended up on immunoglobulin, and she died within a period of about 5 years of respiratory failure, but that was a missed pediatric diagnosis, you might think. On the other hand, she was 28, so she was also an adult as well by the time we saw her. And this is another very curious one, and again, we were talking about interstitial lung disease, how little we understand it. But this is a 20-year-old guy, has his first job. He's trying to climb a ladder at work in Connecticut. And he goes down to Employees Health, and they listen to his chest, and somehow somebody does a chest x-ray, and then that ends up getting a CT scan, and this is his CT scan. I take a look at that x-ray and I just feel sad, because I know this guy's not going to live. This guy's probably not going to see 40 years old unless we can think of something, but we can't, because these are going to be T cells and B cells and fibrotic cells that have invaded the lung so much that we actually cannot backtrack him. You could say, well, he's not an adult. Well, he was 20 when he was found. It could have been the year after. It could have been 4 or 5 years later as well. But the bottom line is the horse is out of the barn here, and we are not going to be able to do a great deal with him. His immunoglobulins are very low. There's your numbers again at the side. So unexplained interstitial lung disease, bronchiectasis without a reason. Even if you are a smoker, it doesn't make you A-gamma globulonemic. So those patients have something in common. They are into the sandwich classification that we call common variable immune deficiency. And I admit Madison Avenue needs to work on that term because it's so completely forgettable. You know, common, like what the heck does that mean? Variable, that's not very illuminating either. And then immune deficiency is kind of like all over the place as well. But that's the current category. And when I look back, I've seen probably somewhere around 900 patients with common variable immune deficiency since my first patients I ever saw at Sloan Kettering. So how do you define it? The IgG is going to be low, and that's usually going to be less than 400. Almost always the IgA is low as well. Antibody function is reduced or absent. In other words, you could have an IgG of 400, but if you do not have binding antibody to tetanus, diphtheria, measles, mumps, rubella, in other words, nothing useful there, then you might as well not have it at all because it's not functional. Lymphocytes are there. Usually they're working what you think is being pretty good. The T cells are pretty good. T cell dysfunction has been enumerated. I've done a lot of work on the T cells of these patients over time. They don't work wonderfully, but they're not the main culprit either. And we've spent a great deal of time in the past, I would say 2 years, 3 years, working on the genetics of this syndrome, because the patients who seem to go down south very quickly, and I'm going to tell you about a few of them, are those who are likely to have an actual single gene missense mutation or frame shift mutation, which actually tells me a whole lot about why B cells work in the first place. So I don't know, you probably have heard of common variable, I suspect, but the first case actually was described in 1954. It was in the New England Journal of Medicine. And the reason why I put this up is that I keep thinking that the author, Sanford, must have been really scratching their heads because the year before, also from Mass General, came the first reports of the males with X-linked A-gamma globulinemia, who were all children, males, and little boys. So all of a sudden, here comes a lady who's 50, 54, whatever her age was. She certainly wasn't a youngster. And she's just as A-gamma globulinemic as the males. And that's why it's in the New England Journal of Medicine, basically, because I think it must have been a shocker to them to realize, oh God, it's not babies. And oh gosh, it's not males. You know, all of a sudden we have something else happening altogether. So I'd love to interview that guy and ask him what on earth was he thinking, and was he as surprised as I think I would have been if I were back in that era. So I've told you about the chest a little bit. Now I have to tell you just a little bit about others. This is another patient of mine. She again is an attorney, and she was discovered late as well. She was at the time 39. She was on vacation in North Carolina. She had and went to the doctor because she was having pain in her leg, in her foot. And they said, oh, you know, it's probably gout. And I'm thinking, I don't know about that. I don't know. I wouldn't probably have diagnosed gout on this either. They didn't do an X-ray at the time. Within 3 days, she was in the hospital in North Carolina with her foot much more swollen, also bilateral pneumonia and septicemia. Strep pneumoniae again. She had pneumonia, so this was evidently hematogenous spread from her lungs to her joint. And then she got better with vancomycin and ceftriaxone and such, but she is hypogamma globulinemic as well. So what could we have done better there? Well, she had strep pneumoniae bacteremia. So bacteremia itself would be very unusual in a healthy 39-year-old woman, and coincidentally, she's explaining that she has this pretty bad joint pain or foot pain, and then she has pneumonia. So it's a little bit much at the moment. It's hard to explain how that could happen. So my threshold for ordering immunoglobulins would probably have been pretty low, and I'm hoping that yours will go down as well. And the reason to sort of go into that is that most people who have common variable immune deficiency are not diagnosed as children. They're going to be diagnosed between the ages of 20 and 40. It doesn't mean you can't be diagnosed sooner, 20% are, or afterwards, another 20% are. It's just this is the way the bulk of those patients will come in the door. It might be a woman who says, I've just given birth to my second child, and I thought my pregnancy had given me pneumonia. Not so much. It's really going to be, that's the typical thing that maybe a woman might be doing in those years. A person who moves or sets up a new practice or that sort of thing. People will find all sorts of excuses for what's happening to them, but in their middle years, this is the diagnostic sort of pathway in which hypogammaglobulinemia is reasonably common. So yes, we followed quite a few, and lung disease, if you look over time, those patients don't just have a simple hypogammaglobulinemic picture necessarily. There could be things that get added on, and over time, I seem to be collecting the patients that have more and more of the complications, such as the lung disease, chronic lung disease, such as chronic autoimmunity, especially thrombocytopenia, especially hemolytic anemia. We have quite a coterie of patients with gastrointestinal disease. It looks exactly like Crohn's disease, but it's not. Granulomatous disease, mistaken for sarcoid, but it's not sarcoid. Hepatitis, but it's not viral. It's going to be autoimmune of a weird sort. Good number of my patients have had a splenectomy in the past. I think 8% now have had lymphoma. A good number have had other sorts of cancers, and of course malabsorption because of the bad lung disease. So this is a case in point. This is a guy I saw pretty recently. He was referred actually by our pulmonary service. So he's a 35-year-old African-American guy, and he has dyspnea, abnormal chest X-ray, hilar adenopathy. Bronchoscopy shows granuloma. So what would you think? Sarcoid. So would I. So did everybody else. So that was age 35. I saw him when he's 46. So he told us when he came in that he had known that he had some well people had told him that he had a low white cell count for years. Okay, that can happen. Splenomegaly. Splenomegaly and sarcoid? Maybe. Lymphadenopathy with sarcoid? Yeah, I guess we can do that. Recurring infections? Well, then we went through what the infections were. At the age of 10, a parotid biopsy said he had granuloma. Okay, still sarcoid. Looks sarcoid, doesn't it? Pericarditis? That goes with sarcoid? A bit of a stretch. Dyspnea, abnormal chest X-ray, bronchoscopy, as I said. Then he begins to have skin infections. From the skin infections, he developed septicemia. That's a little bit over the top. Conjunctival biopsy, granuloma again, sarcoid again, treated with steroids. And then he has cellulitis complicated by bacteremia. This guy, if you talk to his history, has been through the emergency room about 5 times for serious infections, for fevers, and then for bacteremia. And this is then he goes to the sarcoid group at Mount Sinai, and his X-ray doesn't look all so terrible or anything, but his immunoglobulins are low, and he has no functional antibody whatsoever. So that's why he's getting infections, because he has no functional antibody. Look at that IgG, for example, 243. Does that look very low to you? Remember, I told you 1,000 was normal, but some people walk around with 300 or 400, 500. Some normals do. It's not overwhelmingly low. It's low. The A is low and the M is very low too, so he doesn't have much backup there. But the point is, to know exactly how bad he is, you actually have to ask either Quest or LabCorp to tell you whether he has any antibody that works. So that's a red top tube. That's a serum test. You can send it to any of those labs and say, is there antibody to tetanus, diphtheria, measles, mumps, rubella, chickenpox, anything you want. We usually do a panel because I want to know how bad it is. We usually immunize as well with Pneumovax, and we do a post-Pneumovax antibody to say, did you make antibody or you didn't? So this guy it's interesting because he was carried as sarcoid for basically 30 years. So it's been shown, and there was a lovely article in the Annals of Internal Medicine from Hopkins some time ago that said if you put the name sarcoid on the chart, the chances that anyone will go back and think about hypogammaglobulinemia is very small, and the lag time for correct diagnosis can be as much as 20 years. Well, he beat that, actually. He was more than 20 years. So systemic granulomatous disease occurs in 8 to 20% of the common variable immune deficiency patients. The granuloma may be in the lungs, the lymph nodes, the spleen, the liver, the skin, the brain, or the bone marrow. It can be anywhere. So seeing a granuloma does not tell you that it's sarcoid. Just kind of remember that. And some of them have had a positive Cunningham test, in case any of you remember what a Cunningham test is. Maybe they don't. you guys remember what a Cunningham test is? Some people do. Okay, a few people do. Okay. Well, some of them can have, and the ACE doesn't help you either, by the way. So please don't worry about the ACE. It's not going to help you. Because these patients have ACE too, because their immune system is struggling. So this is a 38-year-old man. He's exposed to 9/11, the dust cloud, 2 episodes of pneumonia. He has splenomegaly on the last admission. And then he develops ITP. This is a picture of his skin at the time. He has interstitial lung disease on the x-ray, red dots on the skin and low platelets and such. He has common variable too. So how would you know that? Well, he has interstitial lung disease. Yeah, but he went to 9/11. So you keep on finding excuses for what you see, but the point is, does it add up? Well, he has ITP. So for me, somebody who has this combination would automatically make me want to order quantitative immunoglobulins as well. And so he's a patient I followed for some time as well. Because you're always trying in medicine to figure out how is this put together? How do we put this picture together? How do we formulate this for ourselves? And this is a case from Cornell. 46-year-old guy, previously healthy. He owns a construction company in Westchester County. Hemolytic anemia 3 times. And it's pretty bad. And then he has a clot to his kidney, clot to his spleen. He has a splenectomy, which certainly didn't do him much good. Then he has a collapsed lung. He has empyema. Then he has pneumonia again. And he has no gamma globulin. None at all. So, I mean, if you're me, you look at that, and I'm sure you're thinking the same thing. He's hypogamma-globulin-anemic. What excuse does his immune system have to be Coombs positive hemolytic anemia when you don't have hardly any IgG to go with? It's a conundrum, isn't it? It doesn't change the fact that this is the case. This is exactly what he had. Hemolytic anemia, Coombs positive 3 times, followed by the hematologist at Cornell. And yet he has almost no gamma. That's because the only gamma he has is the bad stuff. It's not the good stuff, it's the bad stuff. And this can happen. So hemolytic anemia 3 times would cause that as well. You could say, well, you know, he had the pneumonia, he had the splenomegaly, and then he had lost the spleen, so that's why he had the empyema and the strep pneumoniae bloodstream infections. Maybe. On the other hand, look at the whole picture. The whole picture is screaming autoimmunity. So autoimmunity is a very big deal for us. We see lots and lots of it. Most of it's hematologic. ITP, Evans syndrome, autoimmune hemolytic anemia, a little bit of organ damage, such as rheumatoid arthritis, and you've looked down the list, some of the other ones as well. We've seen practically every autoimmune disease known to man, but the commonest, overwhelming, most common are the top ones there. So for me, a person with several episodes of ITP, they tell you they've had ITP. I would do a quantitative immunoglobulins. I understand that's getting added to the ASH guidelines in case anybody here is in hematology. Just go ahead and order that test and you will have excluded it. For gastroenterologists, I put this one in. This is a 30-year-old guy, severe IBD, maybe ulcerative colitis, lost 20 pounds, copious bloody diarrhea. He got some steroids, started on Asacol, partial remission. He did a little better, still very, very skinny. Past medical history, had pneumonia in college. He didn't have any other infections. He goes to another doctor, says, I'm not really doing that well. He goes to somebody else, has a repeat endoscopy and colonoscopy. And the pathologist says, you know, by the way, just PS, there's no plasma cells on the mucosa biopsy. So does anyone know what that would mean? Always that means one thing. It means, oh gosh, we didn't order quantitative immunoglobulins. Because, you know, that's the key feature actually right there. So it's a bad way to get your diagnosis is to do a colon biopsy, but that's what happened to him. So I know that was really a weird one. So of course he has no immunoglobulin, he has no antibody, and that's why he has no plasma cells, and that's why he has the IBD. And I would say somewhere, it's a very odd thing. This happens to me about 2 times a year. Somebody will call me and say, you know, my patient has no plasma cells in some biopsy of some organ. And you think, okay, well, that's why, because they don't have the B cells to begin with. So 8% of these patients with these antibody problems will have GI disease. And it may be parasites, it may be bacteria, it may be viral infections, it may be nodular hyperplasia. That one over in the upper left-hand side is a guy who lost 100 pounds, lives in Royal Oak, Michigan. I always remember where he lived because I like that name of that town. Anyway, Royal Oak, he came to see me because he's extremely immune deficient, but he also was actually, his problem was not the immune deficiency. It was the fact that he could not really keep any nutrients in his body because he doesn't have any absorptive surface left over. Pernicious anemia, lymphoma. We've had 3 or 4 lymphomas of the GI tract in our patients. Celiac disease is a little more common, and then the inflammatory bowel disease as well. So 8% have this. Loss of plasma cells is the characteristic. So that's something that the pathologists will write on their report. And by the way, who's in gastroenterology? You're in gastroenterology. Does your pathologist mention plasma cells or no? If they don't mention it, then I would call them up. And I would say, you shouldn't be paid for that report. That's my opinion anyway. Because it's the absence of something, right? The absence of something doesn't ring any bells. It's the presence of something. But the absence of something really helps a lot. So I'm showing you this picture, which is probably politically incorrect because I actually have my photo on here as well. This is a sunny day in Central Park quite a long time ago. And I'm showing you that because most of these people are dead, aside from me and my nurse. Autoimmune, endocrine disorder died, B-cell lymphoma died, rheumatoid arthritis died, empyema died, actually had hemolytic anemia before that, died of respiratory failure, heart-lung transplant, respiratory infections, and neutropenia. This is the face of hypogamma. You could pass these people on the street, in the subway, in Gristedes, in supermarket, in Zabar's, and you would not know by looking at them. They actually had a very, very profound immune deficiency. And that's the point of telling you, is that you cannot tell by the way that they look because they're adults. Adults do not have that failure to thrive appearance, generally speaking. The patients who have the complicated issues that I just told you about do actually much worse than this. This is Kaplan-Meier survival for the 473 patients or so that we simply followed for a period of I don't know, I took on my Sloan Kettering cohort and everything I could find from the Sloan Kettering before I was there and took all that data. And if you are hypogammaglobulinemic, you will have a 58% chance of survival if you're a female, 51 if you're a male, over that 4-decade period of life, which in comparison to your age-matched peers is significantly diminished. By the way, this number is very similar to the European standards because my friend Helen Chappell in Oxford, England, did the same thing for their cohort. But these are the ones that have the complications. This is the inflammatory bowel disease. This is the interstitial lung disease. This is the autoimmunity, the splenomegaly, the lymphadenopathy, the malabsorption. And they have a very, very 11-fold chance of dying within the next 12 years. So that's why you really need to pick them up. Okay, so that's about it for the hypogamma. I have to just sort of tell you that I need to go to a few other cases and a few other scenarios. I don't know if you've ever heard about this particular syndrome or not. This is a 50-year-old architect, and he went to his wonderful internist who said, listen, I fainted. And the internist did something that I haven't done for a long time. He percussed the chest. Have you guys percussed a chest for a while? I haven't percussed a chest. Maybe you probably percuss the chest all the time. I don't. I mean, I listen to the chest, but I don't know if I percuss it. He percussed the chest and he said, oh, there's something going on over here, and took the x-ray, and this is the x-ray. So as you can see, something is really happening pretty dramatically over there on that side with his esophagus being pushed way over and also his trachea being pushed way over as well. So he has something that then when he finished having the thymoma removed at Mount Sinai, everyone said, okay, that's cool, now you're okay. A year later, he went to an allergist, one of our attendings at Mount Sinai, and said, that's great, I had this thymoma, but I'm still having all this sinus stuff. So she drew his immunoglobulin levels, and he turns out to have none. So he has a syndrome called Good syndrome, and nobody knows what this is all about. I still don't understand it at all. It's named for my mentor, Robert Good, first described it, and it gives you one of the other syndromes that we don't really remember very well. You know about myasthenia gravis. You remember red cell aplasia, right? This is the third member of the team, which is Good syndrome. And it's kind of like you pick your target, and you can go down one of these pathways. You don't go down all three necessarily, but this is the agamma-globulinic, hypogamma-globulinic pathway. And what you do is you mess up your B cells. B cells, you do not find any in the peripheral blood and very few in the bone marrow or tissues. So there's something very strange that the thymus tissue is doing to combat those B cell progenitors. It's a very odd syndrome, but don't miss it. And the only way to really know about it is to make sure on your chest CT. I think the thoracic surgeon at Sinai was a little bit stunned to realize this was a possibility for a patient. He didn't really know about the good syndrome being an option. But since then, we have probably about 5 patients with this particular syndrome. And this one actually stems from this hospital here. And this is actually an interesting one. He's 25 years old, 2 episodes of Haemophilus influenzae meningitis. He had sepsis, renal failure, loss of vision, and 2 episodes of pneumococcal sepsis. This is all at Bellevue. So past medical history, he had ITP and he had a splenectomy when he lived in Minnesota, and he was known that he was IgA deficient. Okay, so if you have no spleen and you're IgA deficient, does that buy you everything in paragraph 1? It's a stretch, right? That'd be a lot. There are plenty of people who walk around with no spleens. IgA deficiency is about 1 in 1,000 people who have met before. And yet they don't give you this problem of number 1. So at Bellevue, they thought the same thing. They thought something's got to be wrong. So they thought, okay, maybe you have HIV. And it was not absolutely out of the question, but he didn't want to have it. He said, no, I'm not doing that. His CD4s were normal, and his IgG was pretty good, 650. And this is where he met Roosevelt Hospital, BI West. This is now about Sinai West. Got to get the name, but at the moment it was Roosevelt. And it was actually Arthur Engelhard, who was one of your allergists. And he said something is wrong. So he got admitted to this hospital for another admission, subsequent admission. And Arthur took a look and said, okay, IgA deficiency can sometimes be associated with IgG subclass deficiency. And it turns out that he has no IgG2 or 4. And that is synonymous with making no antibody to any encapsulated bacteria. So about 12%, according to the Swedish study, for the US it's probably a little bit less, of people who are IgA deficient will have a secondary immune deficiency of having no G2 and no G4. And so, of course, he was massively immune deficient, no bacterial antibody, no spleen, and no IgA. And that explains it. So basically, I think Arthur saved this guy's life by that blood test. I don't order subclasses very much, but this is the reason why if you ever read in a book, yeah, don't worry about that test, you order it too much, don't even do it. To be honest with you, I am never going to say that because of this guy here, because I think that it was the way that this guy then got put into health. So he's no antibody, and of course he had all the other antibodies he was supposed to have. And that's because the IgG subclasses have slightly different functions, but the IgG2 has a little bit of a special characteristic, which is that it's a little bit more responsible for antibodies to the polysaccharide vaccines. That's going to be Pneumovax, Haemophilus, what you walk around with. So he had none, he'd never had a vaccine, but he wouldn't make an antibody even if you gave him the chance, because he does not have that piece of equipment. And so that was what was wrong. Just going to tell you about a couple other cases, because you probably think I'm totally addicted to antibodies, so I just have to give you a little bit of an antidote about a few other patients that I've seen over time that didn't have something wrong with their antibody, but they actually had a very, very significant immune deficiency. And the ones that adults, internists will see are going to be slightly more in this unusual category. Neutrophil defects, for example. So this is a very sad case, because this is a medical student. She's a medical student at Yale. And she was exposed to compost while she was gardening. She developed fever, cough, and pulmonary infiltrates. She didn't have any bacteria that were isolated. She goes to the doctor. The doctor says, what have you been doing? Okay, well, I'm sort of allergic. Got this antibody to aspergillus. She had IgG and IgE were found in large amounts in her blood, so they thought she has ABPA, bronchopulmonary aspergillosis, right? Pretty sensible. Gave her steroids. But the history has another wrinkle, which is that when she was a child, she was also treated at Yale. She had an elevated IgE. And somebody had thought maybe she has hyper IgE syndrome, and she was given prophylactic antibiotics all the way through high school, but she stopped. She says, I don't think I have to do that anymore. So she proceeds through college and into medical school. A month after her exposure, she wasn't any better, and a lung biopsy was suggested, but being the very smart first-year medical student that she was, she said, I'm not doing it. You have to make doctors do what they want, even if they're a medical student. So the dose of steroids was increased. 2 months later, a lung biopsy was finally done. By this time, she was in the intensive care unit at Yale. She had the lung biopsy, and it showed hyphae and necrotizing granuloma. They started amphotericin, but then she died of respiratory failure. So what do you think? I need you guys to weigh in here. Be my consult. How do you put this together now? Yeah. So she's a girl, right? CGD is supposed to be a boy thing. But remember that, you know, the third of them are going to be the autosomal variety. This is a lung biopsy, and that was Aspergillus, and she got that from the compost. That would not be the first death. Steve Holland has a few. I've had a few of a patient who becomes your patient, doesn't start as a patient, of course. Coach on a basketball team, somebody who goes on a hayride, Aspergillus goes down into the lung. It's bad. It's a very bad scenario. At St. Luke's recently, do you all know that case? The CGD case at St. Luke's, yeah, uptown. The people taking care of her did a fantastic job. They pulled her back from the brink, really. I didn't think she was going to survive. So she again was autosomal, right? Now she was a known diagnosis, but then ran amok because she wasn't taking her prophylactic antibiotics, I think. Isn't that the story?
She's still not out.
She's still not out of the woods? Yeah. Yeah, this girl has a brother and a sister, both of whom are also affected. Her brother's career choice is landscape gardening, which I think I hopefully talked him out of because I don't think that would be a good choice for him. And this is why, because the oxidative burst is composed of several different components, and the X-linked form, which is the GP91 form of that, is on the X chromosome, and it's true, and most of them are males, but we do have a fair number of females, and they will not look as you think they should. And so that was a mistake in ABPA because, yes, she has a great deal of IgE antibody and a great deal of IgG antibody because her immune system is always over-challenged producing antibody to microbes. So I think I only have 2 more cases, and this is one of them, but they're going to be the same, which is that, or similar anyway. This is a 45-year-old lady who was sent to me by our pulmonary team, and her past history was she had some maculopapular lesions on her arms and legs. She had paniculitis, perhaps, but on mediastinal biopsy, she had Mycobacterial kansasi. She's a school teacher from Long Island. No particular reason why she should have that. She was treated with INH or ethambutol and PZA, and then she develops pancytopenia. And periodically, she's a little bit low in her white cell count. She's got leukopenic. And she's admitted, she is referred to us because of the Mycobacterial kansasi. And I hear about her. We have some blood tests available for her. And by the way, her history also includes the fact that she has 2 sons who have had a bone marrow transplant for monosomy 7. So it's a peculiar history, isn't it? So here's her lymphocyte counts. Now, this was before I ever saw her. And I heard about her, and I got the capsule of the history, and I said, let's pull up her white cell count. So here's her white cell counts here. Nothing too surprising. Her white cells are a little bit medication induced. She's just a tiny bit anemic. Everything else is pretty good. Lymphocytes look a little bit low, neutrophils, but this is the kicker here. And I bet you, and me, same with me, you never pay attention to the monocytes, do you? I don't, especially when they're absent. Like the absence of something never rings any bells. But this is a very interesting ailment called monocytopenia. And I actually reviewed the article for blood, and I thought, gosh, that's a terrible name because in a way she's leukopenic, she's lymphopenic, she's everything. You know, why are you going to hit on the monocytes? But it actually is a monocyte disorder of a certain sort, one more case, which is this one, the same thing, and I'm going to tell you a little bit about that. And you will see patients. I think that we miss these patients probably because they have a very heterogeneous clinical picture, composed of fragments of odd elements that are woven together, but different patients will have different components, but they all will have a very low level of serum monocytes. So this is a nursing student, cough and hemoptysis. She comes from the Dominican Republic, nonspecific pneumonia, bronchoscopy. She has an oval lung biopsy that was already done. They said she had pulmonary alveolar proteinosis. It's a very odd past history. Lipoid pneumonia, interstitial fibrosis. She got some steroids, and then she develops Mycobacterium avium, an Aspergillus. She gets amphotericin. This is all in her past history. She starts Plavix. She's got some chest findings. She's hospitalized again for hemoptysis. Everyone's thinking this is what this must be. And then she comes to our emergency room with severe headache. And here's her counts here. And what she has is cryptococcal meningitis. So I admit this is a very odd syndrome, and it's called mono-MAC, and it's due to mutations in GATA2, which is a transcription factor which is necessary for pretty much every single hematopoietic cell, but it has to do with whether or not your dendritic cells and your monocytes become activated. And that's why you get this extremely strange collection. And because it's autosomal dominant, you only need one copy, which is why she gave her that same copy to her boys, which is why if you ever hear about somebody whose child needs a bone marrow transplant for a monocyte, for a trisomy or any other disorder, it would again be the bells would go off in your head for that being, this doesn't seem right. I think all of us have a collective computer in your brain. What makes sense and what doesn't make sense? So for her, that doesn't make sense, but you could actually now, just from her history, you could probably 100% name it. Collection of ailments that she's had, they're so unique. So no monocytes in your data warehouse here will have patients with no monocytes and mycobacterial infections, and perhaps alveolar proteinosis, perhaps leg edema. In other words, the collection of those things equal something is off. This is going to be an immune system disorder that is probably going to be monogenic. So these are kind of the things that in your brain, when you see patients and they give you your history, it's going to take a little bit of time to put everything together, I know, when you only have a relatively short encounter. But chronic infection, serious infection, odd organisms, lymphadenopathy. Normal people don't have lymphadenopathy. They don't have a large spleen. They haven't had ITP in the past, especially not twice. What if they've had a large spleen and ITP? I can tell you so many patients that have been picked up just by the coincidence of two of these things, for example. Unexplained lung disease, bronchiectasis in particular. I think the girl who said that she had hyper IgE as a child, to me, that would have been on my radar as somebody was worried about her as a kid. Like, who was that? They weren't an idiot. It was somebody at Yale was smart. Somebody thought she had something. Okay, maybe they didn't put the name on it, but sure was there. Chronic diarrhea, malabsorption, weight loss, joint pain, swelling, shingles at an early age. Very occasionally, you'll have an adult who says, you know, I had to have a myringotomy. How many times have you had a myringotomy as an adult? It's very uncommon. So if you sort of like use this on your radar as being the ways that you would say something else is happening. And the other thing is going to be the types of bugs that have occurred are also a bit of a help. And I think that from the standpoint of T cells, we've got that lesson down. From HIV, we learned it really well, which is, you know, thrush and mycosis, lymphopenia, mycobacterial infections, MAI, MAC infections, shingles, and so forth. But the others, I think, probably have still sort of hung out there. We sort of don't always hone in so particularly. So having told you kind of the big picture, now I want to tell you what actually happens also in real life, which is that this is a collection of patients. This is 100 patients. One of my fellows put together data for 100 patients and said, okay, fine, you have 100 patients. These are diagnoses. What did they come in the door and tell you that they had? They had that. Bronchitis, pneumonia, otitis media, diarrhea, bacterial pneumonia, bronchitis, sinusitis. We're getting 3/4 of the way around that pie, and I didn't tell you anything shocking yet. There's a lot of the ordinary stuff, a lot of the ordinary everyday infections. And then if you go on around, then you hit a few unusual, cellulitis, septicemia, and such. So those things are tip-offs, but actually there's also a lot more of the ordinary everyday stuff in these patients. So this is a workup. You do a blood count. We usually do lymphocyte screen, immunoglobulins always, subclasses in some. Get the medical records so you sort of know what you're up against. Test functional antibodies after exposure or vaccination. Complement CH50, you can forget the C3 and C4. I think it's a waste of money. Neutrophil function in some. And of course, treatment options are going to be a lot of various things. For the severe cellular defects, it's bone marrow transplant. The 2 patients with GATA2 deficiency need a bone marrow transplant. I think the 45-year-old lady had one. Obviously, very hair-raising and difficult to get transplanted at that age, but still, I believe it has occurred and was okay. Antibody defects, immunoglobulin replacement. Continuous antibiotic therapy is commonly used, and of course, we're using a tremendous amount of biologics now at Mount Sinai. I'm going to skip that one. So this is the last slide. Just tell you, you're an internist, and you're going to need to know it. And you will be very happy to know it, because when you actually find such a case, you'll feel like, I have saved that patient against a lot of difficulty. I will have actually now put the pieces together that will get this person onto the right road. Antibody defects are the commonest, but they result in infections, autoimmunity, organ dysfunction, increased risk of lymphoma. Mortality is a big deal in these patients as well. And the other thing about adult medicine, as you well know, is that they're going to be all spread out. If you're just a pediatrician, chances are you're handling everything. If you're an internist, chances are there's a gastroenterologist and an ear, nose, and throat physician, a rheumatologist, neurologist, and pulmonologist on board as well. And so things get scattered. So we got to hold it together, and that's pretty much what we really have to do. And I've worked with a lot of great people. This is on the laboratory side, but trying to find out why people's system goes south has been one of the most fun things ever. And it's just a great charge to realize why these patients develop all the things they do. And we now have, I think, genetic background in around 33% of our patients, which makes me feel happy to have gotten to that point. So any questions on your side? Questions? Yeah.
What is the role of,
Yeah.
what's the role of, is there a role for tolerant receptors in common variable immunodeficiency?
Right. The question is, what is the role for toll receptors in common variable immune deficiency? It's something that I've worked on quite a bit. Toll receptors, especially toll receptor 7, 8, and 9, are very, very activating to human B cells. But because the hypogamma-globulin patients with dysfunctional B cells just actually do not have that pathway open to a great extent, because they don't get activated very well at all. So it's a very great, it's a great question. Toll receptor defects in general are very, very rare, genetic defects of toll receptors, and probably slightly more on the pediatric side than the adult internal medicine side.
Thanks so much. Wonderful. Here's my question. When you look back at these patients, is there any clue in something as simple as the total protein, the albumin, the globulin?
Yeah.
I mean, we get 10/20s on
Everybody.
all our patients.
Yeah.
Way too long.
I know. That's a really, really excellent question. The question was, would the normal serum chemistry profile, including albumin and total protein, give you some clues? And the answer is both yes and no. And the reason why I say yes is that Stephen Hollis in Wales has actually done a study to identify patients who were undiscovered using only a massive search in their data records for total protein that was low, and then calculated globulin that was low. And that paper is published, and he does think it's a way of finding some of the unfound. The no part of the answer is that total globulin is a calculated protein. It's everything that's total protein taking off the albumin. So in other words, what you have left over is often called globulin, but it's also alpha-1 antitrypsin and alpha-2 macroglobulin and complement proteins and alpha-1 antitrypsin and all the other hemophilia proteins and literally every single thing else that is not a albumin then goes into that pocket. And because patients who are immune deficient often have elevation of acute phase reactants, then you'll be misled into thinking that they're okay. So sometimes if you take a person who's profoundly hypogammaglobulin, go back and look at the total protein, you'll think, it's a little low, but the calculated globulin was a gram. And I'm thinking, gosh, we don't have a gram here. We got around 100 milligrams, so who's left over? So it's a yes and a no. As I say, Stephen has used it in England, in Wales, exactly that way. And I think I've had a couple of patients referred to me because of that. Somebody says, this protein's low. I think I'm going to check it out a little more. So I think yes, from that standpoint.
Any questions? Let's see, groups. Thank you, Dr.
Okay. Yeah.